Hey, good afternoon, and welcome everyone to this month's Employee Benefits Compliance webinar. I am Jenny Badeau with Assurex Global, and thank you for joining me here today. Today, we will hear from the Benefit Comply team with a very timely regulatory review and legislative update. Before we get into today's content, I'd like to hear from you, our audience, and we're going to start with a polling question. You'll see that come up on your screen here. We'd like to ask you, as you're looking toward next year, what are your company's strategies for its medical plan or plans? You can select all that apply from the options you see on your screen. As you are submitting your selections, I'd like to extend a special thank you to your local insurance benefits advisors and consultants who are partners of Assurex Global for making today's webinar possible. And we do welcome your questions today. If you have any questions at any time throughout the presentation, please submit those over to us via the Q&A function at the bottom of your screen. And we do record these sessions. A link to the recording will be available early next week from the benefits advisor who invited you here today. And I will drop a link to the presentation slides in the chat section here in just a couple of minutes if you'd like to look at the slides and follow along. And I am going to wait just a few moments for the poll responses to continue to come in. And I will mention too, we have asked this question actually for the last several years, and it's always interesting to see how these responses change over time. We have seen a notable shift in responses, particularly in a couple of these areas over the years. I will mention that maintain or decrease the employee contribution has always been the top response here. But last year, we saw 39% of respondents indicated this is something they were going to implement, compared to a high of 84% that we saw in 2022. Certainly, a number of factors play into that. But again, it's always interesting to see how those responses shift. And a sneak peek as those final responses come in, it looks like that is the top response again this year, and a notable uptick from last year's 39% is what it's looking like. I'll give it just a second here and I'll share those results out with you. Okay. So you should see now the results from the poll here on the screen. That maintain or decrease employee contributions, still the top response, up quite a bit from last year, up to 71%. Fairly even mix of the other responses, although almost 30% of you are looking to change your medical carrier to achieve those cost savings. So as always, we really appreciate your responses to these polls. I will give you a heads up. There will be a couple of polls actually right in the heart of our presentation today, and I will have one poll during my closing comments as well. But for now, let's get into it. I'd like to welcome from the Benefit Comply team, Regan Debin, Principal, and Amanda Olam, Consultant. So Regan and Amanda, I will turn things over to you.
Thanks, Jenny, and thanks for joining us, everyone. Seems appropriate. We often try and do a fall webinar that is kind of a catch-up of regulatory and legislative activity, and of course, even more so because we've got the elections just around the corner, both Congress and presidential election this year. And then just in the last couple of weeks, we have gotten a bunch of regulations and updates from the agencies. So this ended up just really being an appropriate topic for this month's webinar. We are going to first just kind of talk about the elections, some of the predictions, and how that could potentially impact some of the legislation and regulatory activity that we see through the end of this year as well as into next year. And then we'll go through and touch on some of the key regulatory, primarily regulatory from the agency's guidance and changes during 2024. And then wrap things up today by showing you some of the proposed legislation that we're watching. Amanda's going to be watching kind of the Q&A as we go through today, so please feel free to send in your comments, send in your questions, and we'll try and get to as many of those as possible as we're going through the content today. But with that, let's first talk about the 2024 elections. First of all, obviously lots of us watching and wondering what's going to happen with the presidential election. Will we stay Democratic? Will there be a change to Republican power? Obviously, the platforms that they're standing on and in the different things that they'd like to push forward as far as their agenda would certainly impact the types of things that we see both in Congress and regulatory action going forward. But want to remind you that the president, one of the things that they have the ability to do is appoint the heads of the different administrative agencies. So when we're thinking about the departments that matter for group health plan benefits, like the Department of Labor, the Internal Revenue Service, the Department of Health and Human Services, and thinking about how they interpret and enforce the different laws that are passed by Congress, the president is responsible for appointing the heads of those and monitoring the direction that those agencies take. So clearly, a switch in parties could impact the way the rules and things that interpret the different laws that we follow, how we're expected to comply with those things. And so watching that, we've certainly seen that as we've seen a switch from Republican to Democratic and vice versa, that we'll have a bunch of rules that are put into place, and within a year of the new president stepping up and appointing new heads of the agencies, really rolling back or switching some of the interpretations on those rules. So that's kind of what I wanted to say as far as the presidential election itself. Not more importantly, but the other piece that plays into this hugely is Congress, and being able to pass the legislation that we follow. So it all starts with the statutes, and then we have the agencies interpreting those statutes and letting us know how to follow those. As we've seen, because this is the current picture of Congress, the House of Representatives and Senate, you can see that the Republicans are in the lead, but not by a huge majority. And so what happens then is it makes it more difficult to pass legislation unless there is truly bipartisan support. And because what happens with a lot of the legislation is they throw in lots of different pieces into a particular bill, they may even have bipartisan support on some or a majority of what's in that potential bill. But then if there are certain kind of sticking points where they can't come to alignment, it makes it really difficult to pass that legislation. And that's a lot of what we've been seeing happen over the last couple years. Importantly, as we look at some of the predictions for what they're thinking for 2024, it doesn't look like that's likely to change. A lot of the different tools that were kind of aggregated to come up with this particular model, they're guessing again that Republicans may come out ahead, but not by a huge majority, again, just by a few seats. And the same thing for the Senate. Republicans coming out ahead, but again, just by a couple seats. So certainly more power on the Republican side in Congress, but again, as we're thinking about the number of votes that's needed to pass different legislation, whether it's around healthcare or what we're doing with our group health plan benefits or otherwise, it's hard to think that we're going to see a significant amount of additional legislation over the next couple of years based on the makeup of Congress. So that brings us to a really important Supreme Court decision that happened this summer. And before we kind of jump into some of the regulatory updates, I think it's really important to understand the potential impact the Supreme Court decision could have on that, changing the administrative power that we're used to. As I just mentioned before, if you look at kind of the illustration here, the stage of the laws and regulations that we're required to follow to be in compliance for our group health plans, as far as lots of different things, all the different laws across the country. Congress is the first step where they get to set forth laws and statutes. Then they do as much as they can in the statutes to lay out their intent, but there are always some holes or some different circumstances that won't be specifically addressed, or they may even direct a specific federal agency to further interpret and enforce the laws that are set forth in those statutes. And that's where our federal agencies come into play. So when we have things that are put in place, whether it's under ERISA or HIPAA 125, the ACA, where they're further setting forth those laws via statute, then the appropriate agencies step in and interpret those statutes, and they give us lots of different definitions. They give us lots more detail as to what we need to do to comply, and they ultimately take responsibility in most cases for enforcing those requirements for our group health plans, monitoring and doing audits and checking into participant claims if they may come up, and making sure that we're following, and then they're enforcing penalties where appropriate. Historically, we've always followed the Chevron doctrine. For over 40 years, we've followed that. And what that said is if we had participants or individuals or entities that challenged the statutes and the agency interpretations, that the court would defer to those agency interpretations, that they would kind of accept that as what's required. What the Supreme Court case did this summer was overturn that. So we still have Congress setting forth the laws. We still have the federal agencies interpreting those. But when those laws are challenged, the court has more power. If the statutory language is clear, the court has to interpret it accordingly. They have to follow what's clearly set forth in the statute that was passed by Congress. However, if it's not clear, they don't have to automatically defer to the agency's interpretations and regulations that they've put forth. Instead, the court could potentially say that they think that Congress intended otherwise, or that the agency overstepped, or that they didn't follow the proper rulemaking procedures, those types of things. Courts have a little bit more power to interpret those laws than was historically the case. So what does that mean for you? Specifically in regard to your group health plan benefits and other benefits that you're offering to your employees, that Supreme Court case had nothing to do with that particular arena. It was a completely different set of facts and circumstances unrelated to providing benefits in any way. But it does still set forth a little bit different framework for when the different regulations that we're following on behalf of our group health plans are challenged. So I gave a bunch of examples here where the mental health parity rules, the Section 1557 non-discrimination rules as implemented under the ACA, the EEOC wellness rules that are tied to fairly having wellness programs that don't violate the Americans with Disabilities Act, as well as the Section 4980H rules or the employer mandate. Those are all originally set in statute. So the framework for all of those different rules we see in statute. But then we have the agencies interpreting, for example, for mental health parity, defining what meaningful benefits are and coverage for core treatments, like we just saw in the final rules recently released, and requiring that we gather and analyze relevant data and include that in the comparative analysis. That's all added to the existing structure that's set forth in statute, but is added completely by the agency's interpretation and rules. Under 1557 non-discrimination rules, for example, on the basis of sex has been interpreted a couple different ways. We just got final rules on that. I believe it was last year, or it may have even been earlier this year. That is already being challenged in the courts. And we've seen some injunctions put in place saying that's not how we should be interpreting on the basis of sex. That's not what Congress meant. The EEOC wellness rules, as far as what we treat as a voluntary medical examination that's not violating the ADA protections, we don't have anything in the statute itself addressing how we apply those rules to wellness programs. That is solely based on what the EEOC has put forth in regulations. And then finally, the 4980H rules in the statute itself, it defines full-time as averaging 30 or more hours per week. But then it's all agency interpretation that says you can use the monthly measurement method or the look-back measurement method, and defines what all we need to include and count as an hour of service. All of those things are added detail that the agencies have given us via regulations.
Oh.
What does that mean for you as employers? Actually, today, it doesn't mean anything. You have to continue to follow the laws. You have to continue to follow the regulations that are put in place via agency interpretations. And we have to watch and see what happens as some of these different things are challenged. And the court decisions, because they're at different levels, some of them are going to have a nationwide effect, and they're going to put a national injunction in place saying that we don't have to follow a particular, maybe even just a piece of what the agency's interpreted. Some of them are going to be at the circuit level, just for kind of an area of the country. Some are going to be state level injunctions. Some of their decisions might not have any broader impact other than for the particular individuals that are involved in the case. Over time, what this could potentially mean is that it makes it a little bit confusing with the different things that are being challenged and different injunctions that are being put in place for us as employers and plan sponsors of your group health plans to understand where we have to follow certain rules and where we don't. What we will really need at that point is further congressional action. If there's kind of debate across the country as to what these different things should mean, how they should be interpreted, we need Congress then to pass further clarification via law to let us know what their intent truly was. The only problem with that is that certainly can take a long time. And second, as I just talked about before, and so these two topics kind of feed into each other, the elections and then this Supreme Court decision, if we have a Congress that's pretty divided, passing additional legislation to address some of these things that are being debated may be difficult.
Mm-hmm. I think potentially over time we may see that the statutes are just written differently. Not only is it going to take longer just because of the makeup, I think, of the different parties, and like you said, it's hard to get agreement and things passed. It may take longer just because they potentially may have to provide a lot more detail just on the first try. So at least hopefully, right?
Right. And to that end, I think that's a great point that, how we write the statutes themselves may change, but also the efforts that the agencies go through. Typically there's, what we'll see is notice for comments. They'll take all of that feedback, they'll write proposed rules, then we'll get another comment period, and then they'll finalize those rules, going through that process, and ultimately kind of some of the leaps that they take in their interpretations. I think we already saw some of that in the mental health parity rules that we just got last week. Perhaps being a little bit more cautious in some of their interpretations and the amount of justification that they give for some of their different decisions. So we may see it change that as well.
I think that's definitely fair given the length of those mental health parity regulations when they came out.
Right. So with all of that in place, now we'd like to start talking about some of these regulations that matter to many of you as employer plan sponsors. The first thing that we want to touch on is Medicare Part D creditable coverage. And this is not new. This whole conversation that we're going to have right now, we are discussing requirements that have been in place for a long time. The reason why we're talking about this a lot this year is that Congress passed, via the Inflation Reduction Act, lots of changes to try and address the cost of prescription drugs and also to address the coverage that's provided more broadly via Medicare. We care in regard to creditable coverage because in 2025, and it's a bunch of changes that are going to be rolled out over many years, but specifically in 2025, they're increasing the prescription drug coverage that's going to be available via Medicare Part D. So they're making several different changes, but one of the key things that they're changing is that the max out-of-pocket that can be imposed on a Medicare Part D plan is $2,000. That's several $1,000s less than what we have historically seen for these plans. So what that does is make the coverage richer. For individuals who enroll in the Medicare Part D coverage for their prescription drugs, they will have more coverage available to them beginning in 2025. The reason why that matters to employers is that if you offer prescription drug coverage, which I know most of you do, you have to compare your prescription drug coverage against the Medicare Part D coverage and determine whether it's creditable, whether it's as good or better than the coverage that's available via Medicare Part D. You have to do that each year as your plan design potentially changes and as Medicare designs change from one year to the next. I'll say it now. We'll try and say this a few times throughout because this is a place where we're getting lots of questions. You do not have to make the determination effective January 1st, 2025, when the Medicare Part D actually changes, unless you have a calendar year plan. If you have a calendar year plan, it all lines up and you should compare your design against Medicare Part D beginning in January 2025. But if you offer a non-calendar year plan, for example, your renewal is each year in July, you don't have to worry about the creditable status potentially changing or tied to the 2025 Medicare Part D changes until you're going into open enrollment and you're renewing your plan in July of 2025. The other key thing I want to say here, and then we're going to get into more detail on the next couple of slides, is just to clarify what your responsibilities are as the plan sponsor. The first thing I want to make sure that you understand is that employers are not required to offer creditable coverage. It's okay if your plan is determined to be non-creditable. There are no penalties associated with that. Your responsibility is to determine if your coverage is creditable or non-creditable for each plan year, and then to communicate that status to eligible individuals under your plan, and also report that status to CMS each year. If you are making the determination and then communicating that as required, you've satisfied your requirements. It is not a problem if ultimately what you find is that your plan is non-creditable.
Even if your plan was creditable and it's losing creditable status, right? You don't have to make sure that it maintains it. You just have to make sure that your notices are updated.
Exactly. So just want to reiterate again, what is creditable coverage? What does that mean? And we use it for different purposes. We have a different kind of meaning behind creditable coverage when we're talking about Medicare Part B than we do Medicare Part D. Here we are focused very specifically on Medicare Part D because that's the prescription drug part of Medicare, and comparing it against the prescription drug coverage that you offer via your group health plan or as an add-on to your group medical plan. When we say a plan is creditable, it means that the value, the actuarial value of that prescription drug coverage is as good or better than the actuarial value of the coverage that's available via Medicare Part D. So as Medicare Part D, that coverage continues to increase, even if you don't make any changes in your plan design, that could potentially change your creditable status because it's not keeping up with the increased coverage via Medicare Part D. That's the possibility. That's what's being communicated in a lot of the headlines as they're communicating about these changes that are coming for Medicare Part D in 2025. So then the next question, of course, that we get asked is, well, how do I even determine creditable coverage? We know that you as employers are not capable of doing the actuarial determination, or I should say most of you don't have that actuary background to be able to do that. In a lot of cases, the carrier for a fully insured plan or a TPA for a self-funded plan is going to provide creditable coverage status. They're going to let you know as your plan's renewing that they've determined your plan to be creditable or non-creditable. And if they're giving you that information, you are safe to rely on that. If the carrier doesn't timely provide it, or you have a TPA for your self-funded plan that doesn't offer that, they let you know, we can't do that for you, we can't determine creditable coverage status, then it is your responsibility as the employer to either apply the simplified method or obtain an actuarial determination. You have two different choices to determine creditable status to make sure that you figure out whether your plan should be treated as creditable or non-creditable for the upcoming plan year. We're going to talk about that more in just a moment. But then just understanding, why does this matter? Why is this so important for employers to determine the creditable coverage status of their plans? It's not so much because you're trying to avoid any type of penalty for your plan or to be in compliance, but more importantly, really important for the individuals who are eligible for your prescription drug coverage, because they have to, once they're eligible for Medicare, make a choice between your group health plan and enrolling in Medicare. And as we see more and more of you employing individuals beyond age 65, that they are an active part of your workforce, this is impacting more and more individuals, that they potentially have access both to an employer-sponsored plan as well as Medicare simultaneously. If they have creditable prescription drug coverage under your plan, they don't have to enroll in Medicare Part D when they're first eligible for it. They can delay it. And as long as they don't go more than 63 days without creditable coverage, they're okay. They'll get a special enrollment when they lose that or are notified of that, and then they can jump onto Medicare Part D. They'll have a special enrollment period and they'll be fine. But if individuals go without creditable coverage, then when they do enroll, they can have lifetime late penalties. And my understanding is that that premium that they would normally pay for Medicare Part D can be increased by 1% for every month that they go without creditable coverage. So just talking a little bit more about Medicare Part D eligibility, Amanda and I are certainly not Medicare experts. You as the employer are not expected to be Medicare experts either. Your broker advisor partners, many of them are able to help you with more of this and maybe even have some assistance for your employees who may be eligible for Medicare if you need that. But just a high level overview so that you can help your employees as they're trying to make these decisions and coming to you with questions. Individuals become eligible for Part D when they enroll in Part A or Part B. So if they delay enrollment in Part A or Part B, or both, I should say, then they're not yet eligible for Medicare Part D. But as soon as they enroll in either one, then they become eligible for Part D. And this issue of, do I have creditable coverage or not, becomes important. Then, as I mentioned before, once they're eligible for Medicare Part D because they've enrolled in Part A or B or both, if they go 63 days or more without creditable coverage, prescription drug coverage, then when they do enroll, they face those lifetime late enrollment penalties, and there may not be anything that they can do to avoid that. Lots of employers, as they're asking questions about this and learning this and thinking about, what if my plan goes from creditable to non-creditable? What does that mean? Do employees have to enroll in Medicare now? You know, open enrollment for Medicare is just around the corner. And what if they miss it because they don't know? It's okay. When your plan renews, if it's currently creditable, and you ultimately find in 2025 or a later year that your plan status changes from creditable to non-creditable, when they actually lose creditable coverage or receive your notice letting them know that they're losing creditable coverage, they have a 2-month special enrollment period. And then as long as they take advantage of that and enroll within that 2 months, they won't face those late enrollment penalties. And that's where your job becomes so important, to make this determination and making sure that you're communicating it so that these employees can understand their options and take advantage of these special enrollment periods when that's appropriate, or make sure that they're enrolling in Medicare Part D if the coverage that you currently provide is not creditable.
We just got a question. This is a great question. And it kind of goes to what we were just talking about, right? The difference between being eligible for Part D versus being eligible for Part A or B. So the question was, if they defer enrollment in Medicare A or B, will they be penalized for not having creditable coverage? Or is it only when they enroll in A or B? So I think the second part of the question is there only late enrollee penalties applicable to Part D? There are also late enrollee penalties that can be applicable to the other parts. That is going to be dependent on if they have essentially active employee coverage. If you have COBRA coverage or retiree coverage, that won't be considered credible for those purposes. But remember, we have a different eligibility we're looking at. It's generally 65 or disability for parts A and B. And then once you are eligible for those and then enrolled in those, then we get to creditable for Part D. And that's where we get into this actual actuarial determination. We don't have that on the Part A and B side.
So simple. It's no wonder we have individuals with lots of questions when they become eligible for Medicare.
Exactly.
Really important to make sure that you're sending them to get more assistance with that, whether it's through your broker partner arrangement who invited you here today, or if you've got another resource available. Again, as you have more and more employees who are, but older and potentially eligible for both Medicare as well as your employer plan, not having to be an expert on that, just having a resource where you can get them more information is ideal. So I wanted to just go through the steps again real quickly. Remember, you don't have to offer creditable coverage. You just have to make that determination. And so your first step should be to reach out to your carrier or TPA as your plan is renewing in 2025 and see if they can give you that status. If they can, then you just jump down to step 3. If they can't give you that status in a timely basis, and you need to get the notices out, you need to report to CMS, then you do have to either use the simplified method or obtain an actuarial determination. The actuarial determination, you have to get an actuary involved. So you'd have to hire an actuary to do that determination for you. But the good news is we've got this simplified method that the CMS offered. They put it into place back in 2009. Originally, we thought that was going away in 2025. That's what their draft instructions indicated as part of the Medicare changes. But they rolled that back. When we got their final instructions, they said, we heard you. There was a lot of objection to taking that away and not offering an alternative to the actuarial determination. And they said, you can have it for another year. You can still use the simplified method for 2025. We're going to take a closer look at this and see if we're going to let you use it for 2026 and beyond. The reason why that's really important is there's just 4 criteria that you have to meet for the simplified method versus doing a full actuarial determination. Still may require a tool or a vendor to help you apply that simplified method. But that simplified method is not directly tied to the Medicare plan design. So you have to offer, for example, generic and brand coverage. You have to offer reasonable access to pharmacies. You have to be careful around some of the requirements on your annual lifetime limits if you have those, or your benefit maximums. The one piece that you do have to meet is that you have to provide a 60%, you have to argue that your plan is expected to cover at least 60% of costs. And that's where you may need a tool that has pulled in some kind of national averages and things to look at your cost sharing under your plan and make sure that it can meet that 60% benchmark, but much simpler than doing the actuarial determination. And we are allowed to use that again for 2025. In fact, that we're allowed to use the simplified method again in 2025. Originally, we thought many plans were going to go from creditable to non-creditable in 2025 based on these changes. Because they're allowing us to use the simplified method for another year, that is less likely to be the case. Under the simplified method, many plans that have historically been creditable are likely to continue to be so in 2025. And then we'll have to see, though, if they allow us to continue to use that method or if they continue to make changes to Medicare, if that will be the case going forward. You can use the simplified method as long as you're not taking advantage of the retiree drug subsidy. If you offer retiree coverage and you're taking advantage of the retiree drug subsidy, you have to get an actuarial determination of status. But many of you, that's not the case. You may not even be offering retiree coverage, or even if you are, you might not be taking advantage of that retiree drug subsidy. As long as you are not taking advantage of the retiree drug subsidy, you can use the simplified method to determine whether your plan is creditable or not. Finally, once you know the status, you have 2 further obligations. You have to distribute that creditable notice to eligible individuals, and the CMS has a model notice for both creditable and non-creditable plans. You technically only have to provide that to Medicare eligible individuals, but because you're not always going to know when you have spouses or dependents or individuals who are eligible for Medicare based on a disability, you're not always going to know. And so what we recommend is that you provide that notice to all eligible individuals. Provide that when they're first eligible, and then make sure that you're providing it annually thereafter. Then the last thing that you have to do is within 60 days of the beginning of your plan year, you have to report creditable status to CMS. So you go online, they have a form that gets filled out, put in information about plans, or if you offer multiple plans, each of those plans indicate whether they're all creditable or non-creditable, or if there's mix of both. They ask you a few questions about how many Medicare eligible individuals you think might be eligible for your coverage, and then you call it a day. It's actually pretty quick as long as you have your plan information available. But I point this out because this often gets missed and forgotten by employers. The carriers and TPAs are typically not reporting this status to CMS on behalf of your plan. So this is something that you as the employer probably have to handle.
We always get asked if there's a penalty if you have missed it for prior years. There is not. But when we think about, we just talked about, right, the agencies that are enforcing these rules and doing audits, I think this is just a good thing to make sure we are checking off. If we are ever audited by any of the agencies, we get to show kind of a clean bill of health on that side. I think they're just going to have kind of a sunnier disposition towards us in general, right?
Right. And individuals really needing this information to make those decisions is the key piece. That does wrap up kind of our discussion, our overview on the creditable coverage requirements. We do have a couple poll questions if you would be willing to respond to these. I know we're asking some questions about 2025, realizing that some of you might still be making decisions about your 2025 plan designs, especially if you have a non-calendar year plan or still waiting on status determinations from a carrier or TPA, or potentially looking at using a vendor to do that. But wanting to understand kind of what you're expecting as far as creditable status and any potential changes between 24 and 25. And then also, if you know who you're relying on to help with that creditable determination. Amanda, it does look like we got one additional question about kind of the timing of when they're reporting creditable coverage or distributing the notices.
Yep. So the question is, are we required to report in February and October the creditable coverage? And I think the question specifically by report, it is report to CMS that we're asking about, right? There's only going to unless you change your creditable status, you're not going to have to report to CMS more than once a year. And then, the same is true for the participants, and you should be in February. Maybe that's when the plan renews.
Yeah, so I think maybe the end of February is the 60 days within the beginning of a calendar year plan. So that's likely when you're reporting to CMS.
And then October in reference to the open enrollment for Medicare.
Probably. Yeah. And so just make sure that you're separating out distributing the notices to your eligible participants and reporting to CMS. You have to do it. I briefly went over it before, but the notices, reporting to CMS is always within 60 days of the beginning of your plan year period. The notice distribution is supposed to go when they're first eligible and then annually. You can satisfy that annual requirement in a couple different ways. Some employers choose to provide that notice each fall in advance of Medicare open enrollment. That's great. That meets the requirements. If you're doing that every fall, you're in good shape. But that isn't actually required. If you distribute it during open enrollment as part of your annual notices packet each year, that would also satisfy that annual requirement and you would be in good shape. So doing one or the other and making sure that you're doing it consistently so that you're sending out that notice at least every 12 months, you should be in good shape.
Yep. And then again, for participants, when they're first hired, because they need to know whether or not they should rely on that as creditable coverage when it becomes an option to them, or whether they need to make sure that they're enrolling in Part D, but then only annually after that. Okay.
I wanted to show here
the
poll results, really a mix. I think around creditable status, that's consistent with what we've been hearing, as well as we did think that a lot of plans were going to potentially change creditable status, and we're finding that not to be the case so often, that lots of plans that are currently creditable may continue to be in 2025. I think that is primarily due to being able to continue to use that simplified method. Then thank you also for those of you that shared kind of who's helping you with that determination. Looks like lots of you are relying on your benefits broker who invited you here today, that they're assisting with that, either helping you get that from your carrier or TPA, or potentially providing some tools in the background to help you with that creditable determination, which is great. There are quite a few of you that indicated that you're getting that from your carrier TPA. And as expected, that many of you are unsure of creditable status for 2025 and not sure where you're going to get that information going forward. That was to be expected. But thank you for participating in that. All right, jumping into the next section, this is going to be a very high level overview. We were joking earlier, but we just over a week ago received over 500 pages of regulations from the agencies, further interpreting what we're required to be doing to comply with the mental health parity rules that have been in place for over a decade. And so I wanted to start with just an overview of the requirements here, because these haven't changed. The framework that we've got in place and that was put in place over a decade ago is still, for the most part, the framework that we're working within, although the comparative analysis was added a couple years ago. So here's what we have to do at a very high level under these rules. For group health plans who offer mental health or substance use disorder benefits, which many of your group health plans do, you have to make sure that those benefits and coverage for those benefits is being provided in parity, that it's as good or better than the coverage that's available for medical surgical benefits. That's kind of the purpose of these rules. Then another requirement is that when the claims are being processed around these types of benefits, if they are being denied or limited, we have to provide notices that are specific to these types of claims, providing further information about why those are being denied and the process for denying those, that type of thing. Fully appreciate that employers are not typically the ones that are handling the claims processing for their plans. So typically this is the carrier or the TPA that is having to provide those notices as they're processing the claims on behalf of your plan. And then finally, to further enforce these requirements, Congress added an additional requirement just a couple years ago that we have a comparative analysis done, identifying all of the non-quantitative treatment limitations that are applied in processing the claims, and going through and analyzing and documenting whether those are being provided in parity for the same or similar kind of NQTLs that are being applied to medical surgical benefits. Just a little bit more of an overview of these requirements. I'm going to skip over on the left. We've got 3 categories that make up kind of how we apply the parity rules. We can ignore the first one for the most part, because when the ACA was passed, it pretty much prohibited any annual or lifetime limits on a broad basis for plans. And so we don't have to worry about those anymore. You really can't apply any annual or lifetime limits to benefits for mental health or substance use disorder benefits. But we do have lots of things under our plan that would fall into what we call financial requirements, quantitative treatment limitations, and non-quantitative treatment limitations. And any of those that are imposed on mental health or substance use disorder benefits have to be comparable to or no more restrictive than the ones that we're applying to medical surgical benefits. When we do that analysis, the circle on the right is the 6 different classifications. We have to take all of the different benefits under the plan, put them into one of the buckets, and then we look at the different limitations and requirements that are imposed on the different benefits within that classification, and have to make sure that the parity rules are being followed. Again, this framework existed before and is going to continue to exist going forward. And they're just adding additional kind of clarification and requirements and enforcement efforts around making sure that this is happening. So what's new in the final rules? They delayed it a year for some portions of the new rules, and this is one of the pieces, but we are required to now provide meaningful benefits for any mental health condition or disorder or substance use disorder that's covered under the plan. That means that when you're providing meaningful benefits, that we have to provide coverage for what is considered to be a core treatment for that particular condition or disorder. This is where we might see some of the more of the plan design changes going into 2026. They give an example of autism in the regs, and they talk about how lots of plans provide diagnostic coverage and some of the initial coverage that may go along with autism once diagnosed. But that not all of the plans are providing core treatment for the condition once it's actually diagnosed. And then that's not in compliance. That's not providing meaningful benefits as required here under these new requirements. That's just one particular condition that they gave an example of. It will be necessary to take a look at the plan more broadly and make sure that meaningful benefits are being provided for all mental health conditions or disorders or substance use disorders by the plan. The next change, and there's been the most confusion around assessing parity for the non-quantitative treatment limitations, or NQTLs, as they're often referred to. Again, this was already a requirement. They're just kind of further enhancing and clarifying what they need us to do around these. They did delay some of this, again, these changes to 2026. So we've got another year to kind of sort through this and bring our plans into compliance. The biggest piece here that they added was the second bullet point around design and application, where we're figuring out what NQTLs are appropriate to apply and ultimately how they're being administered. We can't rely on discriminatory factors or evidentiary standards in designing those NQTLs. And then the other piece that they added, and this is probably the more significant portion, is that plans are going to be required to collect and evaluate relevant data and look at what's happening with these NQTLs in operation, and are they materially restricting access to care more so than for medical surgical benefits. And if what they find after collecting and analyzing the data is that yes, it looked okay when we were first looking at it on paper as far as parity requirements, but when we look at how it's actually impacting access to coverage, it's really restricting coverage to mental health care, for example, that the plan would have to take reasonable action to be able to address those differences. We're going to have to collect that data, and then that's also going to be part of final piece that the rules really focus on, the comparative analysis. They did delay until 2026. That relevant data that's collected and analyzed needs to show up in the comparative analysis, but not until 2026. But already today, we're required to have complete comparative analyses in place, and these are the required content pieces that are supposed to be part of that analysis. So the only thing that we don't have to do in 2025 for these analyses is to collect and analyze that relevant data. That can be pushed out one more year. One thing that is brand new that is going into effect right away, it was not delayed until 2026, was around a certification. If your plan is subject to ERISA, that your plan fiduciaries have to, as part of a complete analysis, certify not necessarily full compliance, because you won't always know that. You have lots of service providers and vendors that are helping you to design your plan and ultimately administer the plan, but that you've gone through due diligence and you prudently selected the service providers in connection with your plan and to do this comparative analysis on your behalf, that you've gone through the comparative analysis that was prepared and kind of have a general understanding and ask questions and are ready to take action where appropriate. That's what you have to certify, and that goes into effect in 2025. So for any of you currently working on an analysis or looking to do so in 2025, this is a new piece that will be part of that, and it won't be a complete analysis without it. As I mentioned already, this is already a requirement. It's not something that you proactively report or send anywhere or distribute to plan participants, but it is something that the agencies can ask for. They're auditing lots of plans. They've told us that this is a one of their primary pieces that they're looking at to enforce, one of their priorities. You also could be asked for it by a plan participant. For example, if their claims are being denied and they're asking for documentation around why and what the plan terms say and how you're ultimately processing these types of claims, the comparative analysis would be a piece of what they could request. If you offer a fully insured group health plan, you get to rely primarily on your carrier to do all of this for you. They will be setting the plan design. They will be processing the claims on behalf of the plan. They will be preparing a comparative analysis, a written comparative analysis that is matching the requirements and the updated requirements. So for the most part, if you offer a fully insured plan, this is not really going to fall in your lap. But the opposite is true if you're a self-funded group health plan. You as the employer are directly responsible for compliance, not the TPA, not the PBM or the other service providers, although the agencies did recognize that in some places they're being found to be co-fiduciaries were challenged. But you as the plan sponsor then, you have to review your plan design for parity, potentially asking your TPA, who you may be relying on for that plan design, to make sure that they're keeping up with these requirements and making adjustments as appropriate. When they're sending out letters to you suggesting that you make changes to your coverage to comply, taking those seriously and potentially putting those in place, asking them questions about their claims processing and making sure that, again, in how they're processing those claims and the notices that they're sending out, that they are complying with the mental health parity rules. And then finally, that comparative analysis. Is your TPA or other service provider going to prepare that on your behalf, which is great if they are. If they're not, will they provide you with the data necessary? Because they have all of that claims data that you need to be collecting and analyzing to pull together that analysis, that then you could get a third-party vendor to help you with, but you would need some cooperation from your TPA to do so. So asking those questions and finding the right vendors to help you comply is your responsibility. You are not going to be able to understand the rules well enough to do the plan design, to make sure that claims are being processed exactly as they should be. You really need to rely on your vendors to do that, but then you have an obligation to select and monitor your vendors to make sure that they are doing that. All right. For the last bit here, we'll lighten things up a bit and go through just kind of at a high level some of the other requirements. We did get some additional restrictions around how we can use protected health information, or PHI, that might be related to reproductive health care. So just a quick reminder, when we talk about PHI, it's information that you're obtaining from your group health plan. Normally, we can use or disclose that information for treatment, payment, and healthcare operations. If we get consent from the specific individual to use that information, or if there's a public policy purpose for using or disclosing that information. That third one is the one that we want to focus on here, the public policy disclosures. Those are going to be more limited going forward when the PHI is potentially related to reproductive health care. If you are asked for PHI that you think might be related to reproductive health care, fully realizing that this is more often going to perhaps be asked of providers and not necessarily of you as the employer plan sponsor of a group health plan, but just in case it would come up, you have to obtain a valid attestation before releasing that information. And they did give us a model attestation form to use for this purpose. And ultimately, if you don't get that attestation, or you don't think that the attestation meets the requirements, even if you've got a subpoena from law enforcement or a court order or otherwise, that information is not being released unless this valid attestation requirement is satisfied first. This change does require you to update your HIPAA policies and procedures around these public policy uses and disclosures, and make sure that the appropriate people are trained on these new changes. That requirement to adopt those changes and make sure that you're operating your plan accordingly go into effect just around the corner at the end of 2024. We also expect to get an updated notice of privacy practices to address these additional restrictions around PHI that's related to reproductive health care. That model notice we don't have yet, likely sometime next year. We're required to begin using that new notice of privacy practices when we're distributing to people when they first enroll. And then, of course, typically it's part of your annual notices packet that will be available and must be required in February of 2026. We also just recently got the 2025 affordability percentage. I think that was just over a week ago. So now we can start making plans for our 2025 plan years. For those of you who are small employers, you do not have to offer affordable coverage. But if you are an applicable large employer with 50 or more full-time equivalents, you are required to offer affordable coverage to avoid potential penalties under 4980HB. That percentage went up this year, 8.39% in 2024 to 9.02% for 2025. The one thing I want to point out is that percentage is what we use if you're using one of the safe harbors, the FPL rate of pay or Form W-2 safe harbor. It also applies based on when your plan renews. So if you are a non-calendar year plan, again, I'll use a July as an example. July of 2025 is when you would start using the 9.02%. Then just a quick reminder that we do have the 2025 HSA requirements. You have to be enrolled in a high deductible health plan, not have any other disqualifying coverage, and not be claimed as another's tax dependent to be eligible to contribute to an HSA. So first of all, then it's important to understand what's qualifying high deductible health plan on HDHP. We have to meet certain minimum deductible and maximum out-of-pocket requirements. Be careful. It does go up from year to year, but be careful with that minimum deductible, especially for family coverage. We see lots of plans with an embedded individual deductible for the family tier of coverage. Make sure that that's not less than $3,300 for 2025. No individual enrolled in family coverage can have coverage available to them other than preventive prior to meeting that minimum $3,300 deductible for it to be a qualifying HDHP. We also got the HSA contribution limits which apply on a calendar year basis. They go up, historically have always gone up from one year to the next, and that's the case again in 2025. Again, they apply on a calendar year basis. But we do the calculation monthly. So if you have an individual who is eligible to contribute to an HSA for only a portion of the year because they only had qualifying HDHP coverage for a portion of the year, or they enrolled in disqualifying coverage for a portion of the year, they can contribute up to 1/12 of this contribution amount for the calendar year. And just make sure that both employee and employer contributions are counted toward that prorated amount. And then the final thing I wanted to mention was just a reminder that we have to do the Gag Clause Attestations again. This is a new requirement that we did for the first time last year. We have to do it again this year. We have to do it every year for our plans, making sure that any of the contracts that we have in place with service providers don't have gag clauses in place. We're required to attest every year by December 31st. You don't have to do this in December. You can actually do it now if you want to, and you're always attesting for the period of time since your last attestation. So for example, it might be, as you're going through open enrollment and looking at all of your contracts and things anyway, that might be the time to reach out to vendors or make sure that you're doing this attestation. The carriers are doing this a lot on behalf of fully insured plans, but for self-funded plans, what we're finding is often the TPAs or PBMs are just providing you a certification saying that they're in compliance, but they're not actually doing the attestation on your behalf. And so there's a portal that CMS has made available that then you have to take that information or those certifications from your vendors, go on and put information about your plan and your service providers and attest that you're in compliance each year. And then finally, I'm sorry, I know we went through these last pieces really quickly, but I do just want to, before we wrap up today and do the final poll, just talk to you about some of the proposed legislation that we're watching. Going back to what we were talking about, creditable coverage, instead, as Amanda mentioned, specific to Medicare Part B, we only have creditable coverage that would allow people to delay enrolling in Part B if it's due to active employment status. COBRA coverage doesn't count. So they're looking at potentially changing that, see what happens. With employer reporting, for those of you that report for self-funded coverage enrollment in your plans, there is legislation that would allow us not to collect Social Security numbers for covered spouses and dependents. Kind of a small piece of what we do on the reporting, but one of the things that causes all kinds of errors. So that would certainly be welcome relief for those of you reporting coverage information for a self-funded plan. We're also seeing several different bills proposing further transparency requirements on hospitals, TPAs, and PBMs. So that wouldn't directly impact how you're administering your group health plans, but could be good news just for the industry and healthcare costs broadly. And then finally, and this is the one that we do expect to see, even if these others don't happen, we do think it's very likely that at least in the end of the year budget bill, we will see further relief that will allow telehealth to be offered at no cost alongside an HDHP and maintain HSA eligibility. We were given this relief during COVID, and then it has been extended a few times since. There are some issues with budgeting that they can't make it a permanent relief, but likely to get another 2 years so that those of you who offer telehealth alongside your HDHP, you can offer that without charging fair market value and still allow the individuals participating to be eligible to contribute to an HSA. So with that, Jenny, I know we need to turn it back over to you. I'm sorry, we're just at the top of the hour, but wanted to do kind of a final wrap up and poll. Thank you, all of you.
Thank you, Greg. Again, thank you, Amanda. You all covered just an absolute ton of content today. Very, very much appreciate that. As Reagan mentioned, before we conclude, I do have one additional polling question for our audience. So if you're able to hang on for just a moment, we would like to ask you about your strategies as it relates to other aspects of your benefits program aside from the medical. If you were with us at the top of the hour, you may recall we asked you about your medical plan strategies for next year. So now we'll shift focus to other aspects of your benefits program. Certainly, we realize this is not an all-encompassing list, but please select any of these that apply to your company. And as you do submit those responses, I will remind you that we did record today's session. So if you would like to revisit the session or share it with a colleague, a link to the recording will be available early next week from that benefits advisor who invited you here today. They will also have a copy of the presentation slides if you didn't have a chance to grab those already. And, we asked you a lot of polling questions today. We are always interested in hearing your perspectives and your approaches. And I do want to mention, we publish the results of the polling questions and provide some commentary and perspectives in a piece we call a market check survey. So if you're interested in learning more about the polls today and kind of seeing how your peers responded, check in with that same benefits advisor who can share that market check survey with you in the next week or so. And if you have further questions about today's content, or maybe you want to discuss it further, again, please reach out to those benefits advisors and consultants who invited you here, and they will be able to assist you. All right, I'll give the poll just another moment here. And we actually have asked this question over the last several years as well. We've seen two of these kind of take turns as being the top choice over the last few years. Offer additional voluntary benefit products and increase access to financial wellness services have kind of taken turns being the top response. Last year, it was offer additional voluntary products. And it looks like, here, I will share the results out with everyone here. It looks like that took the top spot again this year, but you can see increased access to financial wellness services is kind of right there solidly in second place. So again, thank you as always for joining us. Thank you for sharing your perspectives on these polls. That does conclude our time together. Have a great afternoon.